And with that, we'll go ahead and get started tonight. Welcome to everyone. Welcome to this Innovations in Community Care 10-week series of brief talks on important topics in community medicine. Tonight is the third event in our series. My name is Dr. Lawrence LeBeau. I'm the program director for the Wright Center for Graduate Medical Education National Family Medicine Residency Program that organized this event. The speakers you'll hear from each week are faculty members from one of our training sites. And I say one of our training sites because our program is the only national consortium of teaching health centers that have come together to form one ACGME accredited family medicine residency program with osteopathic recognition that operates as a single program with training locations in 4 different states. Our community health center partners are El Rio Health in Tucson, Arizona, HealthSource of Ohio in Hillsboro, Ohio. We have HealthPoint in Auburn, Washington, and Unity Healthcare in Washington, D.C. So our one program really spans the entire country from coast to coast. If you're a student considering applying for a family medicine residency, we'd love to meet you afterwards and answer any questions that you have. We have some faculty and might even have some residents by the time we're through here from our program sites who will be available after this talk to take any questions from you. But recognizing that everyone's time is valuable, we want to keep each talk in this series both high value as well as brief and to the point. So with that brief introduction, I'm going to hand things over to Dr. Tara Simpson from our HealthPoint Community Health Center partner site in Auburn, Washington, for her presentation on the FQHC-Hospital partnership. And Dr. Simpson, it looks like you've already got control of the screen. Go ahead.
Great. How does that look, Dr. LeBeau?
Looks great.
Perfect. Well, welcome to this talk. Thank you so much, everyone, for joining. And Pratik, we're able to see your message in the chat. So thank you so much for joining us. And it's nice to meet you there. As Dr. LeBeau mentioned, I'm Dr. Simpson, and I work here at the HealthPoint site in Auburn, Washington. Okay, so let's get started here. There are 2 stick people on the screen. On your left, you see one called FQHC, which stands for Federally Qualified Health Center. Below that, you see the HealthPoint banner. So HealthPoint is the name of the community health center that we work at here in Auburn, Washington, which, as Dr. LeBeau mentioned, that's one of the training sites in the National Family Medicine Residency. To the right of your screen, you see another stick person, and this one is called Hospital. Below that, the banner says Multicare. That's the name of the community hospital where we work here in Auburn. What we're talking about today is FQHC Hospital partnership. So we're going to use the analogy of a relationship because a partnership is kind of like a relationship. And we're going to ask ourselves, is this a perfect match? We know that a lot of things affect a relationship. Relationships happen in the context of your community. That's what this graphic is here. Relationships come with baggage. This is a suitcase. It represents skeletons in your closet, etc. The baggage you bring to a relationship. This graphic is money. Money is something that really influences relationships and sometimes causes problems. Okay. So let's go back to the beginning. We're going to start with the origin story of this relationship and talk about the baggage. The vast majority of residencies are funded by Medicare. In 2015, the Congressional Research Service, this is a public research branch of Congress, estimated that over $10 billion were spent on residency education. And guess what? The vast majority of this goes directly to hospitals, over 70%. So that's a lot of money, and it all goes to hospitals to train residents. So that's why you see this hospital stick figure person with all these money bags. A little more contextual information. Where residents do their training really influences where they end up practicing. And that makes sense, right? If your residency is in a big hospital in a big city, you're more likely to specialize and you're more likely to stay there. Residents who train in rural areas or community health centers are more likely to stay in those areas for their future practice after residency. The other thing that you have to think about is, would you get the skills you need to practice in a medically underserved area or a rural area if your residency is in a big hospital? Probably not, right? Those are kind of different skill sets that you need. Hospitals are businesses and they want to make money. So remember how they get all that money to train residents. What does that money really go into? A lot of it goes into specialization and getting fancy medical equipment and more advanced subspecialties in the hospital, which makes sense because that's what brings in the money. So that's what hospitals are really going to do. So as you can see, with this system, there's really no incentive for hospitals to ever establish residencies at a non-hospital site or away from the hospital in the community. Along comes the Patient Protection and Affordable Care Act of 2010. Remember, this was the act that expanded health insurance coverage to millions of people in the US. Up till this point, it's been over 28 million people. At the time that the Affordable Care Act came around, though, there was already a workforce shortage of primary care providers, particularly in rural areas and with medically underserved populations in other communities. So how did the government address this? They came up with this really brilliant idea of the Teaching Health Center Graduate Medical Education Program. And the brilliant idea here is to find a different funding source, so not Medicare, and to put it directly into residencies at community health centers. So let's talk a little bit more about that. Here we have our baby stick person. So this is our baby FQHC, or Teaching Health Center. What actually is a Teaching Health Center? The language here is directly from the Affordable Care Act. They are not based in the hospital. They are community-based ambulatory care centers that operate a primary care residency program. There were 11 of them that got started in 2011. They don't necessarily have to be affiliated or be in FQHCs. All of them initially were at FQHCs or affiliated with FQHC lookalikes, and the majority still are. They have different funding from Medicare. The acronym you see here is HRSA or HRSA, and it stands for Health Resources Services Administration. So different pool of money, and it's going straight out into the community to support residencies. What is a federally qualified health center or FQHC? So now our stick person here is grown up. These are charitable organizations that are not for profit. Their goal is to provide comprehensive health services to everyone in the community. Their funding is from the Public Services Act, and they're governed by independent community boards of directors. And another key important part is to be an FQHC and to get the funding from the Public Services Act, you have to be in a geographically underserved or medically underserved area. Okay, so we've met our two stick people. We've realized that they exist within the context of the community that they're in. We reviewed that they both come with baggage and some history, and that money, as with all relationships, is a big part of this. So let's get into the actual relationship. First, we're going to talk about how it affects the community that the FQHC and hospital are in and the healthcare system overall. What we know is that patients who have a primary care doctor at an FQHC use the ER less, use less specialty services, and have less costly admissions than those who don't have one. So what this means is that any area you're in is going to have kind of a fixed pool of resources or funding. There might be some grants, some city, state, other local funds. What this means is that Because you're having less unnecessary ER visits, use of specialists, et cetera, those limited resources can really be targeted much better towards something that the community needs. This helps decrease healthcare disparities, improve access for everyone. It also brings the voice of the community to the hospital, because remember that the FQHC is governed by people in the community. So it helps bring that voice to the hospital. So what is in it for the FQHC? That's what we're talking about now. That's why these little faces with the hearts are on the FQHC stick person. Really, the most important thing is that it lets you bring the mission of the FQHC to provide excellent medical care to everyone to the hospital. So you're really able to advocate for what you care about as an FQHC, which is things like social determinants of health. You might be able to have initiatives in your hospital to use interpreters better, or provide excellent care to people with substance use disorders, or impact changes like that. Another direct impact is use of the 340B program. This is another program that's part of the Public Services Act, and it means cheaper drug prices for patients who go to an FQHC. So for example, in our hospital, sometimes patients will get discharged and they'll go straight to our clinic to pick up their prescriptions because they're significantly cheaper, which means they can actually afford to have them and stay out of the hospital. What else does it mean? We have our very own family medicine service here at our site. We take care of our very own patients, which means we can have really excellent continuity of care. As a PCP, you might see your patient in clinic one day, then take care of them in the hospital, and then be able to follow up with them when they're discharged. A different PCP might be able to call us and discuss an admission. We might be able to redirect it or prevent an unnecessary admission. For discharges, it means that we can really help patients navigate through barriers to follow up. We have a process here where we get their phone number and ask them how they're going to get to their follow-up appointment. We also get to bring members of our community into care. We take care of patients who don't have a PCP. So after they leave the hospital, we're able to follow up with them in clinic. Another benefit, especially for our trainees, is that you get to learn inpatient adult medicine from family doctors rather than hospitalists, say. So that's going to have a somewhat different approach to inpatient medicine. There's a small baby here. What does this really mean for OB, or our pregnant patients? We see a lot of newborns in the hospital, and we get to bring them into our clinics. Seeing more newborns increases job satisfaction for family doctors. It means that residents have increased access to seeing newborns. We have a special rotation just to see newborns rather than barely meet numbers like on an ER rotation. We get to bring our patients out of the hospital faster and prevent them from going back in because we can arrange things like home phototherapy or seeing a lactation nurse the same day. I also think we take better care of pregnant patients on our family medicine service because we really have the patient and family-centered approach and understand that sometimes people play a role in their families and have to do things like breastfeed. The biggest thing here is that we can really bring that patient and family-centered approach and the appreciation for social determinants of health to the hospital. The labor deck is, it's a surgical subspecialty, so that's definitely an area of growth for them. What's in it for the hospital? What's really interesting is when I was reading for this presentation, there's a lot written from industry, like healthcare consulting companies. And what's interesting is a lot of those industry presentations really seemed in favor of this partnership. The most important is that we bring expertise in social determinants of health and the patient and family-centered approach to care. We already know that if patients have an FQHC, they're less likely to use the ER, you avoid hospitalizations. So this lets hospitals direct their resources towards other evidence-based medicine interventions. What about for our pregnant patients? It means that we provide a lot of support that the hospital doesn't have to. We have a really close relationship with the public health department. So for moms who need formula or a breast pump, we're able to help them get that and not have to stay in the hospital longer because they don't have access to these resources. Sometimes newborns have to stay in the hospital waiting for a cardiologist to see them, and that can take a couple days. We just have to call the PCP in the clinic and they can help coordinate an urgent referral. Not right now, unfortunately, because of COVID, but we also offer home visits, and that's a unique part of residency training. Home visits can really help add a layer of support, like to newborns who are having problems breastfeeding, so that they don't have to go back to the hospital. Obviously, no relationship is perfect. These are really theoretical disadvantages, but just to briefly mention them, unlike the Medicare system, where hospitals get all these billions of dollars for their residents, the hospital doesn't get all that money for us to be in the hospital. So we are here because the hospital wants us here and appreciates us a lot. And they want us here more. So this is not a disadvantage of the system here at our site. There's a theoretical risk of competition. That one doesn't really make sense to me. The theory is that the hospital system and the FQHC nearby could be competing for the same primary care patients, but really by its very nature, FQHCs are in underserved areas, so that's really not going to happen. FQHCs and hospitals sometimes have trouble communicating because there's a very close partnership and collaboration, but with different medical records. Okay, so we're gonna wrap up. We've talked about a lot of things. We have our 2 stick people here. We're talking about FQHC-Hospital partnership. We talked about how this exists in the context of community and how there's a lot of baggage and money coming into this. Specifically, that prior to 2010, the only way to really fund residencies was Medicare was giving hospitals all these billions of dollars, and hospitals directly kept 70% of that money. And so they were really more incentivized to keep specializing. But the Affordable Care Act expanded coverage. So we needed a lot more primary care doctors. So that is the birth of the Teaching Health Center GME program, which created funding for community-based primary care training. And this stethoscope in the middle represents the trainee. And as we've discussed, I think there are really a lot of benefits to our community, the healthcare system overall, the FQHC, the hospital, and to the trainee. So I think that's all. Yeah, that's all. I'll stop sharing my screen, but I would really love if Dr. Antia or Dr. LeBeau, this is really your area of expertise. So I would love to hear what you have to share.
We'll wait to see if there's any questions.
Yeah, and any questions or anything like that.
Hi. So not a question, but I was really touched by the point that you made that it's the patient are using the expensive healthcare very less, because I was working in an ER and I can see that thing very clearly, that since they were not having access to the primary care, they had to come to the ER because while they were not having access, they get so complicated. So that was a really great point for me. And that was an excellent presentation. Thank you so much.
Oh, thanks, Pratik. And yeah, you make a really good point that it is really complicated. And I think when we when there are patients and we can see them here, that's what we can really do, is just troubleshoot what's complicated and take away the barriers so they can just, yeah.
Yes.
Any other questions or comments?
Thank you so much, everyone, for being here. And thanks for your question, Pratik.
Thank you so much. It was a great learning point for me. Thank you.
So just as a reminder to everyone, all of these sessions are recorded and will be available for viewing on the Wright Center's for Community Health YouTube channel. I put a link in the chat box for you. And it's a great place to go and watch the series events if you aren't able to make it 1 or more weeks. These will be there available for everyone. At this point, if there are no other questions for our speaker for tonight, we can end this portion of the session. If anyone has any questions, if you're thinking about applying to family medicine residency, have any questions about just our program in general, we're happy to stay on and take those questions from anyone at this time. We have faculty available right now from our HealthPoint site in Auburn, Washington, and also from our Unity Healthcare site in Washington, D.C. And I can handle questions about any of the sites that you have.
Bye, thank you.
Bye-bye, thank you.
All right, and if there are no questions, we'll wrap things up tonight. Thank you for joining us. And I hope you can join us again for the rest of our events in our series. Good night, everyone.